Thank you very much. Can you hear me? I'm not sure if you can hear me. You can hear me well, right? Okay. Assalamu alaikum. Good afternoon. I'm delighted to be here with you today and see many familiar faces as well as new faces. This is my second time presenting at this conference, and it's really a remarkable experience. And first and foremost, I would like to thank the organizers of this conference, Professor Marianne Yusri and her team, for extending the invitation to me to deliver a lecture on movement disorders that we typically see in patients with genetic, developmental, and epileptic encephalopathies. So I have no conflicts or disclosures to report. Epilepsy is the third leading contributor to the global burden of neurological diseases, and it affects around 65 million people worldwide. Epilepsies associated with developmental delay can be categorized into can fall into three broad categories, including developmental encephalopathies, epileptic encephalopathies, and developmental and epileptic encephalopathies. Developmental encephalopathies are early onset diseases characterized primarily by developmental abnormalities associated with some neurological and behavioral changes. But seizures are not the main clinical presentation here, and if they are present, they are usually manageable, and the course of the disease in developmental encephalopathies are usually static. Whereas epileptic encephalopathies presents with multiple seizures, often difficult to treat, and abnormal EEG. And these patients typically present with normal development, and then they start regress or development plateaus with the onset of epilepsy, repeated epilepsies. And it is thought that epilepsies cause the delay. However, in very early onset cases, it's difficult to distinguish actually whether epilepsy or the cause of epilepsy is causing a delay. Hence, acknowledging this, in 2017, the International League Against Epilepsy introduced a new concept called developmental and epileptic encephalopathies, meaning that there are certain group of genetic disorders that present with intractable epilepsy and developmental delay. And the developmental delay is caused not only by seizures, but also by the genetic cause itself. The prototypical example will be, for example, Dravet syndrome. So hence, developmental encephalopathies, and further I will refer to them as DEEs, are the most severe group of epilepsies characterized by drug-resistant seizures, epileptiform activity on electroencephalography, and developmental plateauing or regression. And in my talk, I will be mostly talking about movement disorders in DEEs. DEEs typically present in childhood before the age of 16. In a recent epidemiological study, the cumulative incidence for DEEs has been reported as 169 per 100,000 children. The causes of DEEs are heterogeneous, but most commonly they are genetic. With the advances of next generation sequencing, the genetic basis determined in up to 40–50% of DEEs, and more than 800 genes have been identified. These genes implicate in a wide range of neurobiological functions, including but not limited to synaptopathies, channelopathies, epigenetic regulation, abnormal post-translational modification, transport and signaling dysfunction, and metabolic disorders. To further extend the classification of DEEs and developmental encephalopathies, an ever-increasing number of neurogenetic conditions associated with epilepsy and movement disorders have been recognized. Hence, DEEs are further subclassified into DEDs, which stand for developmental epileptic dyskinetic encephalopathy, meaning that patients will have a DE and movement disorder. So it's very difficult to treat these conditions. Whereas there is another term as developmental dyskinetic encephalopathies, DDEs, and we know that these genes like ADCY5, KMT2B, ATP103, PDE10, they present with developmental delay and movement abnormalities, and seizures might not be a major problem, and they can be treatable in this category. Overall, All genetic conditions presenting with seizure and movement disorders can be categorized under the umbrella term of genetic epilepsy dyskinesia spectrum. And they are, you can see, they are truly remarkably heterogeneous. Hence, hence increased awareness is necessary to diagnose them promptly, and it's important to interpret the results of genetic report appropriately to be able to diagnose and treat them adequately. The presence of movement disorders is often not appreciated in patients with DEEs, and we know why. Because they can be subtle, firstly, and secondly, the main focus will be on intractable seizures. Movement disorders and the hence movement disorders, we can see they are under-recognized in DEEs. Movement disorders can be observed from as early as the second day of life in patients with DEEs up to fourth decade of life. So distinguishing DEEs from epilepsy sometimes is challenging, even for experienced clinicians. So for some genes usually associated with DEE phenotypes, rare patients do not exhibit seizures, or they have very mild seizures, and they can be first referred to movement disorder specialists rather than epilepsy specialists. So hence we understand that movement disorders are under-recognized in DEEs, so we need to learn how to recognize them. As of August 2024, there are 119 DEE genes related, DED-related genes have been reported in OMIM database. And among various movement disorders, one of the commonest movement disorder in DEEs was dystonia, followed by ataxia, chorea, myoclonus, stereotypies, and to a lesser degree, tremor and hyperkinesia. And what are these movement disorders? We know all movement disorders are categorized into two big groups, hypokinetic and hyperkinetic. There is only one hypokinetic movement disorder, which is Parkinsonism, and whereas there are several hyperkinetic movement disorders. And this includes tremor. Tremor is a rhythmic oscillation of any part of the body. So as you can see in this patient, this is Professor Mahazaki's patient with ACBD6 gene. We can see the tremor of the whole body with especially upper limbs, but in this case, the child has a jerky tremor. Whereas myoclonus is a sequence of repeated, often non-rhythmic movements like shock-like movements resulting from muscle contraction or relaxation. So we know the myoclonus could also be negative, right, due to relaxation of muscles. So in this child, we can see the periodic tremor, but also myoclonic jerks in his body. You will appreciate it later on. So this is a myoclonus. What is chorea? Chorea is non-rhythmic, abrupt movements. Basically, it's a series of non-rhythmic abrupt movements that are repeated in random order and resulting from continuous ongoing contraction of muscles from one group to another. That's why patients look like dancing. So if you look at this video, you will see the continuous contraction of muscles non-stop from one group to another. That's why patients look like dancing. And what is dystonia? The most current definition of dystonia by the International Movement Disorder Society, dystonia is characterized by sustained intermittent movements, postures as well, postures, or both. So we need to remember that dystonia is not always fixed. Dystonia always starts with a movement, it's mobile, and then gradually it becomes fixed. But at the same time, the same patient can have mobile dystonia and fixed dystonia. These postures or movements or both. Dystonic movements are typically patterned and twisting, and this actually differentiates dystonia from other movement disorders. Dystonia can be twisting, but also movements are predictable. If we look at the patient, so we can predict what will be the next movement. So because it will follow a certain pattern in comparison to chorea. In chorea, movements are not patterned. And dystonia often initiated by movements or specific task. We know at rest, patient might not have any dystonia, but if he starts doing any voluntary movements, dystonia becomes evident. On this video, you can see more kind of fixed dystonia, but also periodic, tongue protrusion dystonia in the patients with MET27 gene, recently described. But in this patient, you would also notice a pattern in here, right? So facial or orolingual dystonia, but the same movements, same sequence of movements is repeated here, which is more appreciated on this video as well. So I need to stop this video. If you look at this video, this patient from Tajikistan, so he's got brief movements, yeah, like reminding myoclonus. But also, if you pay attention to his movements, they are repeated, so you can predict. So the sequence, turning the head to the right, lifting the left hand, and so on. So there is a consequence of movements that you can predict in comparison to Korea. Here you cannot predict the movements. What will be the next movement, right? And also we need to remember that dystonia is not always slow. Dystonia can be fast, moderate. The speed of dystonia could also vary. And stereotypies, we know they are repetitive, simple movements, often involving upper limbs, as in this case in a child with Rett syndrome. So it's very important to be able to differentiate hyperkinetic movements from each other. Why? Because for adequate treatment, especially, and on top, if these hyperkinetic movement disorders are present in patients with DEEs, we need to differentiate them from different types of seizures. So our task is very complicated. Parkinsonism is interesting because classically, Parkinsonism is defined as the presence of bradykinesia as an obligatory sign of Parkinsonism. No bradykinesia, no hyperkinesia, no Parkinsonism. And with one of the additional signs of rigidity, rest tremor, and postural instability. However, we cannot always apply this criteria to children because Parkinsonism in children, due to maturing brain, can look differently. So we cannot 100% apply. So that's why the definition of Parkinsonism in children is quite vague. But there are several genes in children associated with Parkinsonism. In 2023, Van der et al. Described 77 patients. So this one stopped working for some reason. 77 patients with DEEs and presenting with movement disorders. And they have shown that the most frequent abnormality in patients with DEEs were stereotypies in dystonia, followed by chorea, myoclonus, ataxia, and to a lesser degree hyperkinesia. In 47% of these patients, they had a combination of movement disorders. So it's really difficult to differentiate. And the movement disorders were first observed at the median age of 18 months, from second day of life to 35 years. So you can see the wide range of movement disorders. The authors also found that sodium channels, calcium channels, as well as potassium channels, basically channelopathies, mostly present with dystonia, as you can see in the light gray colored bar, as well as synaptic vesicle trafficking. So you can see the first two bars. They present with dystonia, whereas stereotypies in pink color, they are common as well in synaptic vesicle trafficking disorders, but also they are most common in disorders responsible for transcription regulation. For example, PROF.RAUAN, CDKL5, CHD2, MESP2. And the rest of the biological pathways, like post-translational modification, NMDA signaling, and so on, they have a mixed presentation. So as clinicians, we need to know not only gene and phenotype correlation, because it's not always easy. It's better for us to learn biological pathway where there are many genes and phenotype correlation. But the caveat here is that we need to bear in mind that this is not something fixed, because we are still learning. This figure is not constant. These figures might change because as we characterize deeply phenotype many patients and we will learn more, these figures might change, so we need to bear this in mind. So this is a patient with SCN2A with early onset seizures and also early onset movement disorders, from the first days of life, presenting with perioral dyskinesia, as well as orolingual dyskinesia and upper limb dyskinesia. So you can see, you can appreciate it on the video. And this patient with KCNA2 presented in infancy with mild developmental delay, seizures, but later he presented with unsteady broad-based gait. You see jerky hyperkinetic movements in his upper limbs and posturing. And this is quite progressive, because you will see when he will get older, he will have more, broad-based gait and maybe some signs of hyperkinesia as well. And another category is transporters, as Professor Marian used to represent GLUT1 deficiency caused by SLC2A1. Interestingly, this gene can present with pure movement disorders like paroxysmal exercise-induced dyskinesia or ataxia, or pure epilepsy, various types, including refractory epilepsy. But also, GLUT1 can present with a spectrum of epilepsy and movement disorders, which is difficult to, sometimes difficult to diagnose. But there are early signs that can help us to detect this disease. We know that GLUT1 deficiency can present with various phenotypes depending on the age of onset. And in infancy, it presents with paroxysmal eye-head movements, as in this child. So if you can see this like delay and paroxysmal eye-head movements, you can suspect GLUT1 deficiency, and it's very important to take it early because we can treat it with ketogenic diet. So what are the possible mechanisms that explain the association of movement disorders with epilepsy? Well, it's not clearly unknown, but there are several theories. First, this association results from genes that are ubiquitously expressed or indispensable throughout the central nervous system. And one of the examples will be genes like VDR45, EPG5, SNX14, and so on. So the ubiquitous expression of genes in central nervous system and the resulting abnormality can result not only in epilepsy, but also developmental delay and movement disorders. So one of the examples is autophagy. We know autophagy is very important for all cellular subtypes, and especially for nervous system. And there is an emerging group of diseases called congenital disorders of autophagy, and they have a specific clinical signature. So many genes fall into this category, like EPG5, classically known associated to be Vichy syndrome, but also WDR45, BPAN, brain ion accumulation, types of ataxia, SPG11, well known, probably you have many patients, SPG15, and so on. What signatures do they have? Patient manifest with, as you can see in childhood, they manifest with development delay, intellectual disability, fever-induced seizures, and rarely they can present with spasticity, Rett-like syndrome, and autistic features. But then they are stable. For many years, they are stable up to the age of 15, 20, 30, and from that time, they start progressing very quickly and exhibiting Parkinsonism, dementia, cognitive decline, retractable, pharmacoresistant epilepsy, and unfortunately, patients die very, very early. But EPG5 gene, one of the examples, the prototypical examples of EPG5, is a gene responsible for the final stage of the maturation of autophagosomes. I don't know if you can see my cursor here. So basically, EPG5 gene links lysosomes with, fuses lysosomes with autophagosomes. If this gene doesn't function, there is no autophagy. And we know it has been classically linked to Vichy syndrome. Probably you have this patient, which is quite a recognizable syndrome, prominent with combined immunodeficiency, developmental delay, failure to thrive, oculocutaneous hyperpigmentation, bilateral cataracts, and agenesis of corpus callosum. And unfortunately, this patient died before the age of 34 months. But then, when more patients have been discovered in the world, researchers have identified patients who can survive beyond 35 months, several years, up to the age of 7 and 9. And they suggest EPG5 related disorders present a continuum of variable severity. But later on, we identified patients surviving into adulthood. So as you can see in these videos, these patients from Iran, he presented with mild developmental delay and nothing else. And only at the age of 19, 20, he started exhibiting dystonia, Parkinsonism, cognitive decline, and unfortunately you can see in the second video, he is bedbound just in a couple of years after the onset of dystonia, and unfortunately this patient died quickly. So these are another patients with same EPG5 biallelic variants. For example, these patients from Germany, you can see all of them present with dystonia and Parkinsonism. So this example can nicely show you that some ubiquitously expressed genes can result as in epilepsy, DEs, but also later in life with movement disorders. So the second mechanism is mutations in genes that regulate synaptic function. So there are a lot of regulators of synaptic function, like G protein coupled signal transduction, neurotransmission, synaptic vesicle trafficking. So here you can see a patient with GNAO gene mutation presenting with episodes of exacerbation of hyperkinetic, ballistic, choreic movements and dystonic movements in his hands. And this is another patient with IQ-sec2 gene pathogenic variant. So it illustrates loss of heel strike, so walking, and stereotypies you can see like in red, and so consistent with the red phenotype, repetitive head banging, and so on, apart from epilepsy. So these are all genes responsible for signal transduction. And the third possible mechanism is the gene mutations causing structural alterations in brain. So these structural alterations can form abnormal epileptogenic network or can affect the function of basal ganglia. So there are several genes as well that could be associated with this, and one of the examples is FOXG1. So in this patient, apart from epilepsy, she shows hypertonia, tongue protrusion, so severe truncal hypertonia, and like a lack of purposeful hand movements as well as dyskinetic hand movements. So there are several nice reviews showing us genotype-phenotype correlation. But we need to understand, as I mentioned previously, that many genes and pathways, they could present with a combination of movement disorders, and it's not always easy to make that correlation between a gene pathway and a movement disorder. But still, it's quite helpful at this stage. But also we need to understand that many pathways present with a spectrum. What we know now, today, so might not be true tomorrow. So we need to acknowledge this, right? So as in this case, this NFU1 gene presenting with multiple mitochondrial dysfunction syndrome at one end of the spectrum, severe disease, patients die very early by the age of 30 to 35 months. But at the other end of the spectrum, patients present with pure HSP, surviving into adulthood, but the same gene, same variants, sometimes same variants, but with the same mode of inheritance. So what is the diagnostic workout? So first of all, of course, it's detailed clinical assessment. We need to characterize seizures properly, what seizure syndrome it is, what type of seizures, and so on, and characterize movement disorders, what type of hyperkinetic movement disorder it is, and make this correlation, as you can see in the table. I'm not sure if you can see it nicely. It shows seizure syndromes in the columns, and the hyperkinetic movement disorder, and what genes we can suspect. And you can run panel testing if the panel includes, or gene targeted testing. And if, for example, in Egypt, for some of these genes you have founder variants, so you can check for founder variants. I'm sure there will be many founder variants in Egypt. If it results in negative, if the findings are negative, then you can proceed with the second line investigations, which will include whole genome and exome sequencing. So what are the treatment modalities? So we know that the most bothersome symptoms in patients with DEEs would probably be dystonia and chorea. So hence, the response to treatment is usually unfavorable, we know, in patients, but still it's worth trying. So to treat dystonia, I'm sure you administer this levodopa, benzexol, baclofen, benzodiazepines, as well as botulinum toxin injection and deep brain stimulation. For chorea, so widely administered, we know, dopamine receptor blockers, dopamine depleting drugs like tetrabenazine, valbenazine, and anti-epileptic drugs can also help with chorea. So what is the take-home message from this? Movement disorders in DEEs often under-recognized, mainly because of their rarity and heterogeneity, and therefore delays in diagnosis and appropriate management are common. Movement disorders have a significant impact on the quality of life of patients with DEEs and require integrated management, not only seizures, but movement disorders and the developmental component as well. So accurate classification of movement disorders is important for accurate diagnosis, but also understanding which movement disorder occur with what biological pathway is also crucial for us clinicians. Thank you very much for your attention, and I'm happy to take questions.
Thank you very much, Dr. RAUAN, for this very nice presentation. It's very difficult to categorize movement disorder, especially in pediatric group.
Yeah.
How could we categorize it as a? It's very difficult in neonates especially. We categorize that as dyskinesia, and that's it.
Yeah. So it's a very important question. That's why I just brought up that epilepsies associated with movement disorders can be under the spectrum of epilepsy, dyskinesia spectrum.
Yes, yes.
But
yes.
the more you see patients, the better we will be able to diagnose. As the founder of movement disorders, Professor Marsden from Queen Square, he is the founder of Movement Disorders Society as well as phenomenology. So in movement disorders, there is a concept of phenomenology rather than topic. There is no topical diagnosis. In phenomenology, we need to know what type of movement disorder and where, the location, the duration, and so on. And what he said, our eyes don't see like what our brains don't know. That's why if you see more and more of these patients in video, it's recommended to video these patients, because you might not see it on the day of on the day when the patient comes to you. But when you review these videos, you will see some subtle features that are already defined by Movement Disorder Society, and you can decide whether it's like dystonia or chorea, or if it is a combination of these two.
Yes.
But even if it is a combination of these two, we need to understand what's what movement disorder is more prevalent in this patient, and treat the more prevalent movement disorder.
Thank you very much. Thank you very much.
You're welcome.
Anyone has a question?
Thank you very much. Thank you.
It is a virtual lecture by Dr. Felicity